There is a conversation happening in medical offices across this country every single day. A patient over 65 sits across from a doctor, receives a recommendation for a test or a procedure, and says yes. Because that is what you do when a doctor recommends something. You trust the system. You follow the protocol. What most patients do not know is that some of the most commonly recommended medical tests after 65 carry risks that in many cases outweigh the benefits. Not because doctors are careless, not because the system is broken, but because medical guidelines are written for the average patient, and you are not an average statistic. You are a specific person with a specific health history, a specific body, and a specific set of risks that a 12-minute appointment cannot fully capture. In this video, I'm going to share 5 medical tests that I would personally never accept after 65 without asking very specific questions first, and what I would ask for instead. This is not advice to avoid medical care. It is the opposite. It is a guide to getting smarter, more targeted care that actually serves your health, rather than creating new problems in the process of looking for old ones. Stay until the end, because the 5th test on this list is one that millions of seniors accept every year without question, and the data behind it will genuinely surprise you. Before we go into the list, I need you to understand something fundamental about how medical testing works, and why the calculus changes dramatically after 65. Every medical test carries what researchers call a risk-benefit ratio. The benefit is the information the test provides. The risk is everything the test might cause: false positives that lead to unnecessary procedures, complications from biopsies or imaging contrast agents, anxiety and stress that affect cardiovascular health, and in some cases, treatments that are more dangerous than the condition they are treating. In younger patients, the benefit side of that equation is usually heavier. You have decades ahead of you. Finding something early matters more. Your body recovers faster from procedures. The math favors aggressive screening. After 65, the math shifts. Your body tolerates procedures differently. A false positive that leads to surgery carries more risk than it did at 45. And critically, some conditions that look alarming on a scan or a blood test are what doctors call incidentalomas, findings that would never have caused symptoms or shortened your life, but that once found, set off a chain of interventions that absolutely can. This is not pessimism. This is precision medicine. Knowing which tests to question, which to request instead, and which questions to ask before you say yes, that is how adults over 65 take control of their own health outcomes. The first test I would never accept automatically after 65 is routine PSA screening for prostate cancer in men without symptoms. The PSA, prostate-specific antigen, is a blood test that has been part of standard men's health screenings for decades. And on the surface, it seems straightforward. A high number means something might be wrong. You investigate. You catch cancer early. You save a life. The reality is considerably more complicated. The United States Preventive Services Task Force, one of the most rigorous independent medical advisory bodies in the country, concluded that for men 70 and older, the evidence does not support routine PSA screening. Here is why. Prostate cancer in older men is frequently slow-growing. Many men over 70 who have prostate cancer will die of something else entirely before the cancer ever causes a single symptom. But a high PSA triggers a biopsy. A biopsy carries risks, including infection, bleeding, and significant anxiety. And if cancer is found, treatment options, including surgery and radiation, carry their own serious side effects: incontinence, erectile dysfunction, fatigue, that can dramatically reduce quality of life for a cancer that may have never caused problems on its own. What I would ask for instead: a detailed conversation with your doctor about your specific family history, your baseline PSA trend over time rather than a single number, and a shared decision-making process that weighs your individual risk against the documented risks of the screening pathway itself. The second test I would question carefully is routine colonoscopy screening after 75. Colonoscopy is one of the most effective cancer screening tools ever developed. For adults between 50 and 75, it is genuinely life-saving. I am not questioning that. What I am questioning is the automatic extension of that recommendation beyond 75 without a serious individual risk assessment. Here's what the data shows. The preparation process for colonoscopy, the bowel cleanse required the day before, causes significant electrolyte shifts that older bodies handle less efficiently: dehydration, low sodium, cardiac stress. The sedation used during the procedure carries higher risk after 75, particularly for patients with cardiovascular disease, kidney impairment, or cognitive vulnerability. And the procedure itself, while safe in most cases, carries a small but real risk of perforation, a tear in the colon wall that increases with age. The American Cancer Society and multiple independent gastroenterology bodies now recommend that screening decisions after 75 be made individually, not automatically, based on overall health status, life expectancy, and previous screening history. What I would ask instead: if your last colonoscopy was normal and you are over 75 with no symptoms, ask your doctor specifically whether continued screening is indicated for your individual situation, or whether a non-invasive stool DNA test like Cologuard is an appropriate alternative that carries none of the procedural risks. Before we continue, I want to ask you something directly. Have you ever walked out of a doctor's appointment and agreed to a test without fully understanding why it was being recommended or what the risks were? If that has happened to you, write the word "yes" in the comments right now. You are not alone. And this video exists precisely because that conversation is not happening enough inside those 12-minute appointments. If this information is useful to you, share this video with someone over 65 who needs to hear it. You could genuinely change the direction of their next medical appointment. The third test I would never accept is full-body CT scanning for general health screening. This one has become increasingly popular in recent years, marketed directly to consumers as a proactive way to find hidden problems before they become serious. Walk-in imaging centers advertise it. It sounds responsible. It sounds like exactly the kind of thing a health-conscious adult should do. The problem is that full-body CT scans expose you to significant amounts of ionizing radiation, the equivalent of approximately 400 chest X-rays in a single session, depending on the protocol. The American College of Radiology explicitly does not recommend full-body CT scanning for asymptomatic individuals, precisely because the radiation dose is not trivial and the rate of incidental findings is extraordinarily high. Studies show that full-body CT scans in healthy adults find an incidental abnormality in approximately 40% of patients. 40%. Most of those findings are harmless: a small cyst, a shadow, a variation in anatomy that means nothing. But each one triggers follow-up imaging, sometimes biopsies, and always anxiety. And the downstream cascade of tests that follows an incidental finding carries its own radiation exposure, its own procedural risk, its own cost. What I would request instead, targeted, symptom-guided imaging when there is a specific clinical reason. A chest CT for a patient with a smoking history. An abdominal ultrasound for someone with unexplained abdominal symptoms. Precision over coverage. Specific over general.
The fourth test I want to address is not one to avoid entirely. It is one to avoid repeating too frequently without a clear reason. Bone density testing, or DEXA scanning, is genuinely useful. For women over 65 and men over 70, baseline bone density screening is supported by strong evidence. Osteoporosis is a real and serious risk. Hip fractures in older adults carry a 1-year mortality rate that most people find genuinely shocking when they hear it. Approximately 20 to 30% within 12 months of a hip fracture after 70. The problem is not the initial scan. The problem is the reflex to repeat it every 1 to 2 years, regardless of clinical indication. Here is the reality. If your bone density is normal or mildly reduced, and you are not on medication that affects bone metabolism, repeating a DEXA scan every year or 2 provides almost no new actionable information. The changes in bone density that occur year to year are smaller than the measurement error of the machine itself. You are getting radiation exposure and generating data that does not change your treatment. What I would ask instead, after an initial DEXA scan, ask your doctor specifically what result would change your treatment plan and how frequently rescanning is actually justified given your individual baseline, your medication status, and your fall risk assessment. In many cases, the honest answer is every 5 years, not every 1 or 2. The fifth test is the one I promised you would be surprising. And I want to be careful here because this is nuanced. But the data is real, and you deserve to hear it clearly. The fifth test I would question after 65 is aggressive cardiovascular stress testing in patients who are asymptomatic and have no new symptoms. Cardiac stress testing, the treadmill test, or its pharmacological equivalent for patients who cannot exercise, is one of the most commonly ordered tests in cardiology. And for patients with chest pain, new shortness of breath, or documented heart disease, it is often exactly the right tool. The problem is routine stress testing in patients over 65 who feel well, have stable symptoms, and have no recent change in their cardiovascular status. Multiple large studies, including the landmark ischemia trial, published in the New England Journal of Medicine, found that for stable coronary artery disease patients, routine stress testing and the interventions it leads to, stents, bypass surgery, did not reduce heart attacks or improve survival compared to optimal medical management alone. The test finds disease. The interventions that follow carry real risks, and the outcomes are not better. What I would ask instead, if your doctor recommends a stress test and you have no new symptoms, ask this specific question. Will the result of this test change my treatment plan? If the answer is no, the test may not be serving you. If the answer is yes, understand exactly how before you proceed. Now, I want to give you something concrete. Because this video is not about refusing medical care, it is about replacing low-value testing with high-value testing. Here are 5 tests that I believe every adult over 65 should actively request if they have not had them recently. Tests that are underused, undervalued, and genuinely predictive of the health outcomes that matter most after 65. First, the GFR, or glomerular filtration rate, a simple blood test that measures kidney function. Kidney disease is extraordinarily common after 65, and almost entirely asymptomatic until it is advanced. knowing your number and tracking it over time is one of the highest value things you can do. Second, HbA1c, glycated hemoglobin. This measures your average blood sugar over 3 months. Pre-diabetes affects an estimated 1 in 3 American adults over 65, and the majority do not know it. A single blood draw gives you 3 months of metabolic information.
Third, a full thyroid panel including TSH and free T4. Thyroid dysfunction, both overactive and underactive, is dramatically underdiagnosed in older adults and mimics the symptoms of normal aging so closely that it is routinely missed. Fourth, a 24-hour blood pressure monitor rather than a single office reading. White coat hypertension, elevated blood pressure caused by the stress of a medical appointment, affects a significant percentage of older adults and leads to unnecessary medication. Fifth, a fall risk assessment. Not a test in the traditional sense, but a structured clinical evaluation of your balance, gait, medication interactions, and home environment. Falls are the leading cause of injury-related death in adults over 65. This assessment saves more lives than almost any imaging study. I want to give you a specific framework for how to have this conversation with your doctor, because asking the right questions is a skill, and most patients have never been taught it. When your doctor recommends a test, there are 4 questions that will always serve you well. Question 1. What are we looking for specifically, and what would a positive result mean for my treatment? This forces a concrete answer about what action the test result would actually trigger. Question 2. What is the false positive rate for this test in patients my age? This is a question most patients never ask, and most doctors never volunteer, but it is critical. A test with a 30% false positive rate in older adults is a test that will cause anxiety and downstream procedures for a large percentage of the people it screens. Question 3. What are the risks of this test itself, not just the condition it is screening for? Radiation, contrast agents, sedation, procedural complications. These are real, and they deserve a real answer. Question 4. What would happen if we monitored this instead of testing now? Sometimes watchful waiting with clear parameters is the most medically sound choice. Asking this question opens that conversation. Write these 4 questions down. Bring them to your next appointment. A doctor who cannot answer them clearly and patiently is a doctor worth getting a second opinion from. Before I close, I want to be absolutely clear about something. This video is about questioning routine screening in asymptomatic patients. It is not a framework for ignoring symptoms. There are signs and symptoms that require immediate medical evaluation. Not next week, not at your next scheduled appointment. Today. Chest pain or pressure that is new, persistent, or radiates to the jaw or left arm. Sudden severe headache, unlike any you have had before. Sudden weakness or numbness on one side of the body. Sudden difficulty speaking or understanding speech. Vision changes that appear without warning. Shortness of breath at rest that was not present before. Blood in the urine, stool, or sputum that has not been explained. These are not situations where you ask whether the test is worth it. These are situations where you call for help immediately and let the medical team do their job. The goal of everything I have shared in this video is not to create distance between you and the healthcare system. It is to make you a more informed, more empowered participant in that system, so that when you do need it, you engage with it on your own terms, with your own questions,
and with a clear understanding of what is being done to your body and why.
You have just heard information that most people never receive, not because it is secret, but because the medical system rarely has the time or the structure to deliver it the way you needed to hear it. 5 tests to question. 5 tests to request instead. 4 questions to bring to every appointment, and a clear line between the symptoms that require immediate action and the screenings that deserve a more careful conversation. What I want you to do right now is simple. Go to the comments and write the number of the test that surprised you most. Was it the PSA? The colonoscopy? The full-body CT? The stress test? Tell me, and tell me why. Your answer helps me understand what to cover next, and it helps the thousands of other people watching this video know they are not alone in asking these questions. If this video gave you something real, something you are going to bring to your next appointment, subscribe to this channel and turn on notifications. Every single week, we bring you this level of specific, evidence-based health information designed for adults over 65 who are done accepting the average and ready to demand the precise. Your health is not average. Your care should not be either.